Let's talk about laryngitis, one of the most common, often overlooked upper airway conditions, but one that can cause a surprising amount of frustration for patients, especially if they rely on their voice for work or communication. At its core, laryngitis is inflammation of the larynx, the voice box. Most of the time, it's acute, meaning short-term and often caused by a virus. But it can also be chronic, and that's where we start thinking about more long-term irritants like smoking, voice overuse, or exposure to environmental toxins. And for our singers, teachers, customer service reps, or nurses trying to give report through a sore throat, laryngitis is more than just a nuisance. Pathophysiology and causes. The larynx contains the vocal cords, and when they become inflamed, we get the classic signs: hoarseness, weak or lost voice, throat discomfort, and sometimes a dry cough. In acute laryngitis, this inflammation is typically due to a viral upper respiratory infection. Think common cold. Sometimes it's from voice strain, maybe a screaming match at a football game, or trying to talk over a noisy hospital unit for hours. In chronic laryngitis, we look for ongoing irritants: smoking, gastroesophageal reflux disease GERD, chronic sinus drainage, inhaled irritants, or even excessive alcohol use. Chronic laryngitis can also be a red flag for more serious issues, like vocal cord nodules, polyps, or rarely laryngeal cancer. So duration matters here. The hallmark symptom? Hoarseness. Some patients completely lose their voice. Others describe their voice as raspy, breathy, or unusually deep. Other symptoms may include sore or scratchy throat, dry, tickling cough, difficulty speaking or projecting voice, a sensation of a lump in the throat, especially in chronic cases, swollen lymph nodes, or general malaise if it's viral. Importantly, pain is not always prominent. If a patient has pain when speaking or swallowing, we want to assess more closely for abscesses or something more severe like epiglottitis, especially in children. Assessment and diagnostic findings. Most cases are diagnosed clinically. That means based on symptoms and physical exam. A thorough history is key. How long have symptoms lasted? Any recent URI or illness? Voice strain? Singing, yelling, teaching? Any history of GERD, smoking, or alcohol use? We inspect the throat. Not always easy to visualize the larynx directly, but we assess for erythema, drainage, and lymphadenopathy. In more persistent cases, or if the voice changes last longer than 2 weeks, patients may need referral to an ENT for laryngoscopy, which allows direct visualization of the vocal cords. For acute laryngitis, treatment is mostly supportive. Rest the voice. Complete vocal rest if possible. Hydration. Drink lots of fluids to keep the mucosa moist. Humidified air. Warm mist or steam helps ease irritation. Avoid whispering. Surprisingly, whispering can strain the vocal cords more than talking softly. Analgesics like acetaminophen or NSAIDs can reduce discomfort. If due to infection, particularly bacterial, less common, antibiotics may be prescribed, but most viral cases do not require antibiotics. For chronic laryngitis, the approach is more targeted. Treat GERD if present, proton pump inhibitors, avoiding trigger foods. Smoking cessation is critical. Voice therapy or referral to a speech-language pathologist if nodules or misuse are suspected. Avoid alcohol and environmental irritants. Nursing management. From a nursing standpoint, our goals are to promote vocal rest, encourage adequate hydration, provide education about avoiding irritants, monitor for signs of complications. Patients often need reassurance. Hoarseness can be distressing, especially for those who rely heavily on their voice. Nurses can help set expectations for recovery. Acute cases typically resolve within 7 to 10 days, especially with rest and supportive care. We also teach avoid caffeine and alcohol. They can dehydrate the laryngeal mucosa. Use lozenges or warm saltwater gargles for comfort. Use alternative forms of communication as needed: writing, texting, or text-to-speech apps. Seek follow-up if symptoms persist beyond 2 weeks or worsen, especially for chronic smokers, or anyone with a neck mass or unexplained weight loss. Complications. Laryngitis is usually benign, but we still need to watch for chronic laryngitis progressing to vocal cord damage or nodules, airway obstruction, rare but possible if edema becomes severe, misdiagnosis of malignancy in older patients or those with risk factors. In children, croup or epiglottitis may mimic laryngitis, but have more serious outcomes. Drooling, stridor, and respiratory distress require urgent attention. Discharge instructions should include importance of resting the voice, staying hydrated, using a humidifier at night, avoiding smoke and other irritants, proper hand hygiene to prevent spreading viral infections. And again, if symptoms last more than 2 weeks, especially in adults, they need evaluation by ENT to rule out more serious laryngeal pathology. Conclusion. In summary, laryngitis is common, usually viral, and mostly self-limiting. But as nurses, we play a vital role in educating, supporting, and catching the outliers. Don't dismiss the hoarse voice. It might just need rest, or it might be whispering something more serious underneath.